Hello, everybody. Welcome to this annual general meeting for Gloucestershire Hospitals NHS Foundation Trust. I'm very pleased to see you all here. I'm Deborah Evans. I'm the chair of the trust, and that means that I'm the compere for today's proceedings. I wanted to start by just saying something about how we conduct these meetings. And we have those rules set down on one of the handouts. I'm sure you will all be used to the sorts of standards that we work to. And they include that we want everybody to behave in a courteous and respectful fashion towards everybody else in the room, including towards the speakers. We would like you not to film the meeting or record the meeting. There will be minutes of the meeting published for everybody to see. And some of you will have noticed that we've got last year's minutes here in front of us. So there will be a record of the meeting. I think we've already asked that you don't give out leaflets. There is a place for that, but that's not in the meeting. I'm taking it for granted that those rules will be acceptable to everybody. And if we find that that's not the case, then I may have to adjourn the meeting for a few minutes. But I'm going to proceed on the basis that everybody's happy to abide by that way of working together. Dealing with the business, then, the first bit of business which I need to deal with, and it is, I'm sorry, a bit transactional, is that it is the usual process to approve the minutes of the previous year's meeting. And I can see that some of you were here last year. The minutes are, I think, very clearly written, but they're not short. There's 10 pages of them. So what I'm simply going to do, it's all right, colleagues, just take a seat. You haven't missed anything too exciting yet. What I'm simply going to do is to ask whether anybody has found any inaccuracies in last year's minutes. So I'm just going to pause in case you want to flick through and look. I obviously attended the meeting and I've read them carefully and I didn't find anything that I thought was incorrect, but you may be more eagle-eyed than I am. So I'll just pause for that. Okay. Well, thank you for that. We will accept those as a correct record of the meeting that we had on the 10th of October last year. And we'll go on to the next item on the agenda, which is to take the annual accounts and the external auditor's report. So I want to welcome Karen Johnson, who's our Director of Finance.
Hello. Hello, good afternoon, everybody. I was just sat down actually thinking that this is my 6th annual members meeting here. And so I'm going to spend a couple of minutes just going through last year's financial accounts and then spend another couple of minutes on the current year. So I feel like every year I stand here and say, we managed to scrape through the financial year and we ended the year with a very small deficit. Very small surplus. Let's just take us. Sorry. There you go, some numbers. So we ended the year with a very small surplus against the break-even plan. So the last few years we've had to try and achieve a break-even plan, and last year was no different to that. What is absolutely getting increasingly harder is every year we have to find a level of savings within that plan. And you can see the second bullet point down that last financial year we had to deliver £37.4 million worth of costs out of the organisation. That's after we've been given some inflation and some additional costs to cover growth and pay awards. But ultimately, that's a material amount of savings that we have to make every year. And one of the things that we're finding more of a challenge is that our ability to make that recurrent. So when I mean recurrent, I mean it comes out and it doesn't go back in the following year. So I think I probably gave it the same example as I'm going to give this year as I did last year. But if you've got a vacancy in your budget and you remove that budget, that's gone forever. So that's recurrent. You can't pop it back in. If you hold that vacancy, you hold that budget, but you don't spend against it, so you've got a saving in year, that's a non-recurrent saving because you've still got the budget for next year to go and spend against it. So that's what I mean by a recurrent, non-recurrent split. And last financial year, of that 37 million, we made about £11 million recurrent savings. So you can see the percentage of our non-recurrent to recurrent is growing. And what that means is that when we start next year, we sort of start it as a negative position. So that £24.5 million worth of non-recurrent becomes a gap before you even start next year. But I'll come on to the current year in a bit. So it was a challenge, but we did deliver it, and we've been able to have some successes with some of our transformational programs of work that we've implemented this year, in particular the patient engagement portal. So that's patients being able to book their patients online rather than come in or phone up. And that's still ongoing, but it's making a really big improvement in terms of our patients that are coming into the hospital and just not cancelling at the last minute. So it's really made a huge improvement to them and to our staff as well. So in terms of where we spend our money, you can see there that we get, in terms of our income, most of our income comes from NHS England. That's about 90% of our income comes from NHS England. So I think it's important that we just point that out, because that's the bit of money that's reducing down all the time. So it's important that when we look at our income, we look at opportunities of where we can explore different areas of income opportunities as we move forward. So we don't rely just on NHS England for that income. Our workforce, I've always said this, is our biggest asset. So of our spend, 63% of that is on our most valuable resource, which is our people. And you can see the split there in terms of where that's spent. And then the other areas is on our non-place, so predominantly clinical supplies, services, drugs. But we also have things like depreciation. So running these buildings means that it costs money. And you can see it's quite a substantial amount, even though these buildings are ageing. We still have to sort of create sort of a budget for depreciation costs as well. So that's revenue. So capital, this trust does really well for capital. So you can see we were able to receive £45 million worth of capital allocation last financial year. Our core allocation is about half of that. So we get the more money because we bid for more money. And it's really important we are able to do that because, as I said, we've got quite ageing estate here. And we need to not just maintain them, but actually transform them into making sure that they're fit for purpose moving forward. So you can see the split there around where we've spent our capital money. And each year, revenue is always under pressure, i.e. we tend to be almost overspending. Capital, we struggle to spend in the time frame that we've got. So that 45 million we have to spend within 12 months. If we don't spend that money within 12 months, it goes straight back to Treasury. They take it internally and we've lost the money. Whether we've committed that money or not, it's gone. So it's really important that we try our best to spend that money in 12 months. And of course, you'll see a number of these programs, they're big projects. They take a lot of work, of implementation to actually get in and working and on site within that 12-month period. The Treasury have just started to announce a slightly longer term planning approach. So hopefully that will help us as we move forward into the next few years. But the biggest area of concern for us as a trust at the moment, two big areas, is our estate in terms of our infrastructure and our backlog maintenance and digital. They're the two big key areas that we need to focus on as we move forward into the new year. And then last slide from me. And again, I feel like I'm repeating myself a little bit because I feel like I was doing this 12 months ago, but this year is really tight. You can see that we've got to make 42 million savings this year. So that was 37 last year, 42 this year. On top of about a £7 million system saving as well, because we're obviously part of a wider system. That's 5% of our total plan expenditure, so it's quite big. So we have to try and start focusing on trying thinking differently, doing things differently, because our normal savings programme is just not going to be able to deliver that moving forward. And we're seeing that as we stand here today. So we've currently got about £60 million worth of risk or gap attached to that 42 million this financial year. So we're under quite a lot of financial stress as we go through this financial year, and we're working on how we can deliver that savings in a more sustainable way. Focusing a lot on our estate strategy. So how can we make sure our estates are what we need as we move forward? Can we maximise that income that I talked about earlier on? Is there opportunities for us to do that? And how do we become the best and most efficient organisation and move us forward in terms of productivity? So they're the kind of things that we're working on at the moment. And of course, what we do know with the 10-year plan, the NHS 10-year plan, is that the ambition is to move more services out into the community. So there is a recognition that as we move forward, acute providers will need to shrink. So we will need to make sure that we are in that dialogue as we move forward with our system colleagues. So that's probably all I wanted to say. So I'll hand over now to Jackie, I think.
So colleagues, just while it takes a moment for Jackie to come forward to present the external auditor's report, just to say that it is a requirement at our annual meeting each year that we report on our finance and also on what the external auditors thought of our finances, because they have to sign it off as an independent organisation, and our accounts then go up to national level for approval. So that's the purpose of this part of the agenda. And if you have questions on anything that Karen says, or indeed anything that Jackie says, when we get to the public questions section at the end, please raise those questions about the money. So all Jackie's titles are up here in front of you. I won't read them out, but suffice to say that she's one of our very senior non-executive directors, and she's going to present to you about the external audit.
Thank you, and good afternoon. So I don't actually chair the Audit and Assurance Committee, but I am a member of it. And really the job of the external auditor is to look retrospectively at the year that's passed, and to actually authenticate what the accounts have said, that Karen and the team have prepared, what the various statements are intact and correct, but also they do not just the accounts, they also look at the value for money assessment of the trust, and that's common across the whole country. So they provide their report. It's been through the Audit and Assurance Committee. It's also been through the main board of the trust and to the Council of Governors. So today is the final part of that cycle. So to start off with the good news, in terms of last year, there was some real quite good qualitative improvements. As it says there, that the actual quality of the financial statements and the working papers were of much better quality. The annual report and the engagement of various parties in the production of that were felt to have been really improved on previous years. And there's been some good progress in respect of what they call control improvements, the changes in the way the trust operates, takes decisions, governance, which they recommend. And the previous year there had been 10 such findings. 8 of those have been addressed during the year and 2 remain to be rolled forward, and we're working on them at present. So that's the actual annual accounts. In terms of what they call value for money, and there's a sort of standard assessment across the whole of the NHS, there was previously 4 significant weaknesses. And again, that has been worked on in the last year, and that's been reduced to 2 remaining items, both of which have been either in Karen's presentation or will follow in Kevin's later. So the ones that have improved in year are the ambulance handover delays and also engagement with the internal audit team, who are the people who look at the way that the trust operates its systems in year. The 2 areas which remain to be worked on and improved during this year is the first, which Karen's talked about, is the reliance that we have in our financial savings programme on non-recurrent sources of income, of savings. We have to turn that round and make those things recurrent, i.e. automatic each year. And the second is the Care Quality Commission's regulatory action in terms of maternity services, and we'll be touching that on the agenda as well. So the outcome of all of that, and it's been to the board back in June, was an unmodified opinion, with the exception of those 2 items, the Financial Sustainability Programme and the Maternity Services CQC report. And for those of you as old as me, unmodified means unqualified, which is a tick. It's the best you can get, but the language isn't quite as explicit as it used to be. Thank you.
Thanks very much, Jackie. So that's the external auditor's opinion on our annual report and accounts for last year. And in a moment, Kevin is going to present to you the non-financial aspects of our annual report. But it falls to me as chair of the trust to make some preliminary reflections, and I don't want to steal Kevin's thunder in doing so, but there are half a dozen things that I just wanted to draw out as my reflections of the year. I think the first thing that I want to talk about is how we work as a board, as an NHS body. So NHS boards are made up of executive and non-executive directors. The non-executive directors are the people who are the lay people, and we are in the majority in the board. But we work jointly with the executive, and we're charged with working as one group. And we are collectively responsible for the decisions of the board and for everything that happens in the trust. So I just wanted to, it's not always, I think, very clear about what we mean by the NHS having a unitary board, but that's what it means. And sitting amongst you today are both non-executive directors and executive directors of the board. So when I think about the last year, and of course the last year finished on the 31st of March, and that seems like a very, very long time ago. So I cast my mind back to that year, and I think the thing that is striking is that we have made many and sustained improvements to the way we deliver services, and particularly in urgent and emergency care. And colleagues here like to achieve that by running multidisciplinary improvement events. They often have cheesy titles like the 5 perfect days of Easter or the 8 days of autumn. I'm getting them all slightly wrong. But what happens is colleagues from both hospitals and all disciplines work together to try and crack some of the difficult problems, because these are complex processes that we're talking about. So if I think about the improvements we've made, for example, to the reduction in ambulance handover delays, that's as the result of many different disciplines working together to really tackle some of these problems. And we've gone from being one of the poorest performers in the country to making, really great inroads into that. And that's one of many improvements we've made. So all credit to all the colleagues across the 2 hospitals who've done that. The second thing that I wanted to talk about, and we've been working on this for the whole of the 3 years that I've been in the Trust, is the cultural work. So we had an adverse report from the Care Quality Commission in 2022, which led us to a very sustained staff experience improvement programme. It also led us to doing a lot of work about freedom to speak up, and encouraging colleagues to feel that they can speak up, and we can really see the results of that. We have also been running a programme which is called Licence to Lead, which is a development programme for our frontline managers so that they feel capable and confident in running teams well, and in turn so that team members have a good working environment and good experience of being at work. So all of those things are things which continue. They may not be very evident, but they're working all the time in the background so that we are improving colleagues' experience of what it's like to work with us. We're not perfect. We've come from a low base, but we can show the improvement over time. The third thing, and one that I think is important not to forget when you have hospitals with such ageing estate as we have, is all about prioritising health and safety. And a lot of work has been done on that, the most prominent of which is about addressing the fire risk in the tower block at Gloucestershire Royal. But there's a whole suite of improvements to health and safety which we're needing to make at the moment, ranging from security for our colleagues, whether they're working in the emergency department or on the wards, improvements to the places that have got asbestos needing removal, and improvements to the safety of our water system. So there are many, many health and safety issues, and we are making a concerted effort to address and deal with all of those, both for patients and for colleagues. The next one I wanted to mention, because I was with the appeal board chair this morning, is our cancer appeal. And some of you will have been around Gloucester and Cheltenham and seen the Lions and our Lions at Large appeal, which is just into its last few weeks. But it's all part of raising the profile and raising funds for our cancer appeal. So an enormous amount of work has gone in from volunteers to make that happen, and I feel very proud of that. One of the things that we're going to talk about later on in the agenda is the role of our governors, and Andrea Holder, who is our lead governor, is going to talk about that work. But I had the pleasure this past year, of shadowing each of our staff governors. We have staff governors and public governors, and the staff governors come from different disciplines. So I wanted to see the world through their eyes and to learn more about their perspectives and their places of work. So, and some of them are here today. I won't embarrass them by shouting out their names, but I am very grateful to have had that opportunity. And while I'm mentioning governors, we have a governor here who has come to the end of 9 years as a public governor, Pat Eagle. And I just wanted to take the opportunity to thank her in public for all the work that she's done for us. Next one. Yes, we have a what's called a wholly owned subsidiary in the Trust. It's called Gloucestershire Managed Services. Some of the colleagues are around here today, and it's probably not quite right to say it's estates and facilities, because it's much more than that, but it provides a lot of the services we need to keep the hospitals running. So whether it's linen, whether it's portering, whether it's catering, whether it's cleaning, whether it's estates, there's a whole lot of services that they run. And I have the pleasure with its chair, Kaylor Fox, who's one of our associate NEDs, of going on tours of the parts of the hospitals you don't normally see. So I just wanted to acknowledge and pay tribute to Gloucestershire Managed Services, because they are going from strength to strength in working with us and underpinning the day-to-day delivery of care. two more things that I wanted to talk about. One is our leadership team. And I want to say that I have very much appreciated the leadership of Kevin McNamara, working with all his executive colleagues and with the clinical leaders in each of our divisions. They've been working together very successfully. And I wanted to particularly highlight that Kevin took the decision when he first came to the Trust about 18 months ago, that in the light of that BBC Panorama programme about our midwifery services, that he felt it was important, in a spirit of openness and accountability, that we commissioned external reviews of our neonatal and maternal mortalities to make sure that there weren't any lessons or any gaps in what we'd already learnt, to make sure that our improvement journey was as full as it needed to be. Nobody asked us to do those reviews. We decided to do those ourselves. And at our board meeting a couple of weeks ago, was it just last week? It feels like a year ago. At our board meeting last week, we took those reports in public, and they're the culmination of a lot of work, and it's improvement work which continues. So I just wanted to give credit to the executive and our clinical leaders who are working tirelessly to improve care here. Now, I've said a lot of positive things, and then I've got a heading that says not everything has gone well. So these things range from a very difficult time with a critical incident we had in the depths of winter in January. The fact that our phlebotomy colleagues are out on strike and how uncomfortable we feel about that for them and for us. The fact that we broke even, although it was very difficult to do that financially, and so we've got a mountain to climb this year in terms of finances. I've presented a positive picture overall, but I want to acknowledge the things that have been much more difficult for all of us and which I feel sorry about. The last thing to say is that there are lots of changes afoot in the NHS. We will be part of those changes, and in the new strategy that we're publishing, we're looking in particular about how we can be good partners to other players in the system, and in particular about how we can support the emphasis of moving to neighbourhood health services and supporting primary care. So on that note of the future, I'll hand over to Kevin.
Deborah, thank you. Afternoon, everybody. I'm Kevin McNamara, Chief Executive of the Trust, and I've been in the organisation for about 18 months now. I'm going to take you through some of the things that Deborah's talked about. I'll just show you some of the data that sits behind all of that, but I'll step back a little bit from the finance. We'll touch on it ever so slightly because obviously it's a big driver of some of the areas that we're going to focus on. I also want to draw attention to some of the things that we are still struggling with as an organisation. And one of the things that I've always sort of reflected on in this sort of job is that when you come into it, you inherit about 101 problems. And then when you leave the job, you'll leave 101 problems. Now, the hope is that the 101 problems are a different list of problems for someone else to pick up. Some of the things that that I'll talk about are things that I think have been stubborn issues for the organisation over many, many years. And what we've committed to as an executive team and as a board is that there are some issues that we don't want to kick the can down the road, so that we don't want other people to have to pick some of these things up. Now, it doesn't mean that we'll leave things in a perfect state, and we'll replace one problem with another. But it does mean that some of those things that I think you, as particularly as the membership, may have been reflecting on over a number of years, saying, why isn't the Trust sorting some of those things out? And I'll get into what some of those things are. This just gives you, I shan't read these numbers out so you can have a look at them. This just gives you a sense of the scale and scope of what we do as an organisation. This is what we do over the course of a typical year. One of the statistics that I always sticks in my mind as well is £2.3 million a day we spend in this organisation. So I always think about that when people say, actually, we don't have enough money. Actually, we spend an awful lot of money. Now, the question is, are we spending it on the right things? And that's the constant challenge. And of course, there will always be a need for more. But of that £2.3 million, about £150,000 of it a day we do not have. So that sort of goes on the Trust credit card, which starts to build the problem for future years. years, which is our underlying deficit, which Karen alluded to. But that money, 2.3 million, goes into hundreds of thousands of patient contacts every year, ranging from the urgent and emergency and the unplanned right through to the electives. This time last year, we talked about some of the things that, it was my first annual members meeting here, we talked about some of the things that we wanted to focus on as an organisation. And what I wanted to do was I was having a look back through some of those things just to show where we are now. You'll see some progress, you'll see some things that are still stubborn, and we'll talk a bit about what we want to do there. About 2 months before I joined the organisation, I was at a national meeting where we were pulled into a room. We were at a national meeting and about 10 trusts were pulled into a room at short notice, which is never a good thing at a national meeting. And we were asked to talk about our ambulance handover position. And in that meeting, what I realised between where I was in my previous trust and where I was coming into Gloucestershire, I was effectively responsible for about a quarter of the country's handover issues at that time. And so it made me realise just how sort of high profile, particularly in Gloucestershire, those issues were and are. And we've got some of the people in the room that have been really key to driving those improvements. And one of the real lessons out of some of this work, some of this improvement work, is actually not about shiny new ideas, but it is about the consistency with which we apply what is proven to work elsewhere. There's also something, the intangible bit, about self-belief and confidence that there's something that we can do as an organisation that will change the situation for patients and for staff. So I want to just talk you through a few slides on improving flow. Flow is one of those technical terms that we use in the NHS. Probably any normal person wouldn't use the word flow, but it is about how patients come into hospital, move through the hospital and get discharged in as seamless way as possible so they don't get stuck unnecessarily at the different stages of their journey. That is not just about their experience, but it is about safety, because we know when flow is poor, there is something called delay-related harm that we quantify, that we're very public about, that we want to tackle. So it's a real driver of safety as well. So on ambulance handover delays, what this shows is the number of hours lost. It runs from about June 23 right up to now. Number of hours lost per month in 2023 versus 2025. So 3,343 hours in 2023 on average per month to 1,366 hours per month. So that hours lost doesn't really mean an awful lot for folk outside of the NHS. But when you translate that into ambulances back on the road, which is what the focus of that work has been, it means on average 12 crews are back on the road and not outside the emergency department every day. So that means there are people now getting, hopefully, quicker access to an ambulance than they would have before. When we translate that down into time in minutes, you'll see that chart, a different chart, but you'll see that reduction over time, and particularly the peak at around winter 2023-2024, and that's the number of hours lost each day, and you can see 170 hours lost each day in January 2024. Now it's around 20 hours each day. So that's a huge improvement that the team have led themselves in that. And that again is making a difference. Last year, we were asked to, I think because of the position that we're in, and we're in a challenge position, myself, Al Sheward, our Chief Operating Officer, were asked to be involved in something called the Regional Ambulance Handover Group, because the South West has the worst ambulance handovers in the country. So it is a particular challenge for the South West. And so there was something that we developed in one of the groups I was involved with called the Timely Handover Protocol. Not without sort of criticism and not without sort of challenge, but it is about setting the standard to say we will not accept long delays outside the front door. And what we want to do is hold to offloading ambulances, getting patients into the department as quickly as we can. That timely handover protocol we adopted early in that process. And that's been one of the things that set a standard within the organisation. Now, as I said, some of that translates into a different problem. So we still have patients then that can wait too long in the emergency department to get access to a bed. But that's where, going back on this previous slide, one of those snappy titles that Deborah alluded to, the clinical vision of flow. That's a piece of work that we've got a number of clinicians in the organisation that are working together to really think about how can we work differently to support flow through the hospital. The really important part of that is it is a clinical vision of flow. So it's not a manager vision of flow. It's not us in a darkened room telling the organisation what it should and shouldn't be doing. What we're doing is holding the mirror up to ourselves, say, okay, what else can we do? How do we generate a different sense of belief in some of this? A few months ago, we were in this room to bring all of those folk together, all of the teams together, to talk about where else we can go. And one of the things that was palpable in this room, was the fact that not only are people coming up with new ideas, but there was a real sense of belief that we can still go further on this. And one of the tests on this is we had a couple of clinicians that I reached out to who would best be described as folk that would normally keep their arms folded and not want to get involved and be slightly sceptical about this. And they're now leading this sort of work, and it is making a difference. There's a whole host of other things that we need to do to build on that, because the national expectations are only growing. And of course, with the ambulance service under significant pressure, that displaces pressure onto us. So there's lots of other things that we need to do. But that gives you a sense of where we are in ambulance handover times. And you'll see the variation that crops up. So there will be times this winter when we will face some very difficult days. But what we're aiming for is that trend to continue to come down. Nationally, the expectation is that we reduce ambulance handovers to below 45 minutes, so that we wouldn't ever have anybody waiting more than 45 minutes. But you can see there that a push there to 30 minutes. So there's still more to do on that. As I mentioned, so we can offload patients into the emergency department, but then actually what happens when they're in the emergency department? Are they then sitting there for hours and hours? One of the things that we were particularly keen to focus on this year was the number of long waiters, and that's measured nationally on 12 hours. Now, 12 hours is a fairly sort of arbitrary figure, because actually harm starts to occur, or increases rather, when people have been waiting longer than 8 hours in the department. But you can see where we are at the moment as a trust. So we are towards the wrong end of the table, but you can see a steady sort of increase there in terms of improvement. So the number of patients that are admitted or discharged within 12 hours. So that is one of those areas that we've made some improvements, but there's still a lot to do. What that improvement meant was that last year, so the last financial year, we were one of the best performers in the country in terms of improvement, so one of the top 20. We got some additional capital money. So when we think about the backlog issues and some of the things that we need to do, we got some very important capital money, very useful capital money to help us on some of that. So that just sort of shows that if we can deliver against some of these metrics, there are some incentives financially, but most of all, there is a patient incentive there, is that it will reduce harm. And then I think the last slide, just on urgent and emergency care, the 4-hour target was one of those things that has been in the NHS for a very long time. It's gradually changed from, I remember about 15 years ago, 98% to 95%, and then obviously COVID sort of blew lots of the targets apart. And one of the things that we really want to push on, and when I talk about the elective work that we are doing, we've got some really good elective access times. We want to make sure there's a parity there with emergency access times as well. And you can see this is one of those areas that has been stubborn. We've seen some slight improvement during the course of this year, but there's a big focus, particularly through the rest of this year, about what else can we do to deliver a bit of a step change when it comes to the number of patients waiting within 4 hours, being seen, treated or admitted within 4 hours. And you'll see patients split out into major and minor. Minor patients are, sometimes it's necessary to have them in a place like this, sometimes it's not. So it's important that we work with other system colleagues, that they also pick up some of those patients that automatically at the moment are defaulting to the emergency department. And one of the ways that we're doing that is before, Al describes ED sometimes as before it would be like the hotel reception. So to get access to a bed, you needed to go through the hotel reception. So ED being the hotel reception. What we've been spending a lot of time doing through things like the clinical vision of flow and working with our clinical teams is providing more direct access points to beds and to admissions, sometimes without the need for a bed. So same-day emergency care, somebody can come into what we call a hot clinic. They can be seen, treated and discharged, so they don't ever need to be in a bed. Because, of course, as soon as somebody's in a bed, we then generally test and test and test, and they can often get stuck within our organisation. So that just shows you sort of that shift. And places, particularly in Cheltenham, things like the opening of the HASU, the hyperacute stroke unit, making a real difference so we can get ambulances straight there rather than having to navigate through ED. One of the things that you will be familiar with in the NHS are patients that don't need to be in a hospital. They're ready to be discharged, but they are waiting for a care package, either at home or in a nursing home or a care home. And as with everything in the NHS, we use a snappy sort of abbreviation called non-criteria to reside. And just as everybody gets used to what that means, that we then change it to something called discharge ready date. And so if you, I still stick to the old money version, which is non-criteria to reside at the moment. But you can see here that the number of patients in and around July 2022 that were in the hospital that didn't need to be here, around the 230 mark, there or thereabouts, and you can see that reduction. We as a system have worked well at delivering a real improvement in getting patients back home or back in their normal place of care. But we did set ourselves an ambitious target of 87 because we know that if we can hit that target, we can generally run quite efficiently as an organisation. We've plateaued for a bit, and you'll see the sort of uptick over this summer. Today we've got 130 patients in our hospital that don't need to be in our trust. That obviously takes up beds, it takes up resource, and so some of the solutions to our financial challenges are making sure we're treating patients well and in the right settings of care. So this is something that we continue to do, and even though we have made improvements, we don't want to sit on our laurels there. What we've got to do as an organisation is translate the improvement that we see there into an improvement in things like access times in the emergency department, because sometimes there's not a direct correlation. In the same way that when we've delivered improvements in ambulance handovers, there's not a direct correlation in the response time for ambulances on the road. So, but you can see that improvement going on there. So that's the urgent and emergency care side of things, probably the most visible part of what we do, and often the thing that gets the newspaper headlines. But the other part is around elective waiting times. Post-COVID, every NHS organisation saw a massive growth in elective waiting times, the waiting list, and really sort of drifting away from what was the 18-week target. So to be from referral to treatment, that it would be within 18 weeks for the vast majority of patients. This is a real government target. That you will see that the government set some manifesto commitments that waiting lists would be tackled. So I'll just take you through where we are at the moment. So waiting list, 52 weeks. The patients that are waiting over 52 weeks, for over a year for treatment. I can remember on the eve of COVID in my previous organisation, I was summoned to the regional office to talk about why we were declaring a breach of 6 patients that were going to be waiting over a year for treatment. It was seen as a big no-no. And then you can see what happened during COVID. We just saw this big wave then of patients that I think the NHS had been managing just to keep its nose above water. And then obviously COVID really sort of pushed those numbers higher and higher. And so you can see we peaked well over the 3,000 mark just last year, a number of patients waiting a year for treatment, and you can see that reduction now. I think we were down to, we've got Alex Matthews here, who's our Deputy Chief Operating Officer, who's driven this with the divisions to deliver this improvement. And we're now around the 30 mark, so we're into sort of very small numbers. We can name them individually in terms of patients that are waiting on that list. Now, of course, things like resident doctor strike action creates risk on these, because we are working at that level where anything can sort of tip you back into having to recover a higher number of patients. So, but we've almost eliminated the number of patients waiting 52 weeks. And then we've moved on to the number of patients waiting 45 weeks, because at every turn, when we've addressed the 104-week backlog, the 78-week backlog, the 65-week backlog, the 52-week backlog, we're now getting into the 45-week backlog. And again, you can see that reduction during the course of the last year or two. But again, slight uptick towards the summer there that we just are paying attention to. Now, averages are provide context. That's not, that's helpful. But within this, there are some specialties that are particularly challenged. So there are some specialties where that average won't apply, and so we have to pay attention to those things as well, and not lose sight of the patient impact, particularly in some challenged specialties. Some of that is about efficiency of processes. Some of it is about team working. Some of it is about some specialties recruitment challenges where we're really struggling to get the right number of staff in there. But all of that has translated into the trust being ranked 10th out of 152 trusts in England for 45-week performance. And at last count, we were the 10th best overall when it came to 52 weeks as well. So making some really solid progress there. And this is what I mean about if we can get urgent and emergency access to be on a par with our elective access, I think that would make a real difference to the people of Gloucestershire, and that's what we're grappling with as a team. And then 18 weeks. So these are the number of patients on the waiting list waiting over 18 weeks, and that's the national standard. That's the constitutional standard that the government wants to get back to. We were asked to join something called a Pioneer Programme earlier this year, which is a handful of trusts that could go further, faster, and we're hopeful that we can do more of that. What it also often means, hopefully, fingers crossed, is you can get access to some funding as well. So there's another benefit for that work as well. One of the other areas that we pay particular attention to is our diagnostic performance, and there's a technical term called DMO1. It's a fairly dry technical term, but diagnostic performance. And that's about the number of patients that are waiting 6 weeks or more for a diagnostic test. Because, of course, the quicker we can give access to a diagnostic test, the quicker, if patients need treatment, they can get onto a treatment pathway. And you'll see here that we are rated more in the sort of green section. The grey bars are what are called our peer trusts. So those are trusts that are similar to ours. That you're comparing apples with apples more rather than just comparing us with a small organisation or a specialist trust. Now, we could just look at that slide and say, we're in the greens, therefore we don't need to talk about it. What we've struggled with over the past number of months, though, is our 6-week performance has dropped. It's deteriorated. So we're still better than a significant proportion of the NHS, but we know there is some focused action and activity that we're having to do to make sure that we recover that drop that we've seen to get to the national expectation and ultimately to top decile in that. And then cancer. I'm going to canter through these ones fairly swiftly, but cancer is one of the big national asks as well. You can see here, this is our 28-day performance, so that's diagnosed or ruled out within 28 days, and this is where we are towards that end of the spectrum. 62 days, this is where we are just on the cusp of between the red and the green there. Again, this is one of those areas that that variation within specialties, some specialties can drive, even just small numbers can really impact our performance there. But again, it's something that we are focused on as a team. And then one of the areas that we were grappling with last year was what we called our SHIMI, our mortality indicator. That's the summary hospital level mortality indicator. And this is one of those stats within the NHS that actually is a big issue for organisations. And you might remember Mid-Staffs many years ago, HSMR, it's one of those organisations that had a very high hospital standardised mortality ratio. During the course of the year, you can see, and over the course of the past 2 years, you can see that our mortality indicator has climbed up to the middle part of last year. Mark Pietroni, our medical director, has been leading some work, again, with clinical teams and with clinical coders to really focus on how do we improve that position. And you can see that starting to come back down, and so we started to bend the curve there. So again, that's another one of those important indicators of quality, but it's also an important indicator about whether we are coding activity properly within the organisation. Are we capturing what patients are coming in for? And ultimately, it's a measure of, there will be some patients that come into the hospital that it would be expected that they will pass away, and there are some patients that will come in with a really low-level issue, and if they pass away, that will be something that would be flagging and contributing to this data. And it gives us an opportunity to ask different questions at a specialty by specialty basis. The other area we talked about last year was improving patient and staff experience. And so I just want to take you through a couple of slides there. And I do want to talk about maternity very shortly. Just last week, we had the National Inpatient Survey published, and this just gives you a sense of the sort of the headlines. And we've got folk within the organisation that are really focused on trying to drive up and improve patient experience. The inpatient survey is one thing. We have the maternity survey, we have the outpatient survey, we have the cancer survey, so we have a number of other CQC surveys. But you can see there the areas where we are positive in that survey. So top 5 trusts for your care and treatment, kindness and compassion, respect, dignity and overall experience. But then areas where we need to focus improvement on. So involving patients more in decisions, cleanliness of hospital room or ward, information about meds and length of time on waiting lists. And it's really interesting, when we look at that and then correlate the length of time on waiting list concern there with what we're seeing through what the slides I showed you earlier, there's a disconnect there that we need to pay attention to. Things like the cleanliness of hospital room or ward. Some of that is about the ageing estate, but some of that is about our sense of pride and are we really focused on delivering improvements in that environment for patients. And one of the big it shouldn't be a revelation, but one of the real bits of learning for me personally through the maternity work is the involvement of patients in their care. And obviously in maternity, that is something that's it's a statement of the obvious, but I think actually there's been plenty of times when we haven't got that right. And there's lessons and experience there across the rest of the organisation that we need to pay attention to. So you'll see that nationally as well, out there in the public domain. I'm going to see whether, unfortunately, you can't quite see the grey lines here. But back in 2022, we were one of the most deteriorated trusts nationally when it came to the aggregate score in the NHS staff survey. So there's a real level of concern there. You can see number 64 out of the provider, the 2 providers that are used for the staff survey. The one that we used, we were 64 out of 65 in terms of negative reduction there. This last year, we have been able to make some progress over the last couple of years. We were 5th out of 58 amongst these trusts in terms of most improved, but that is from a low base. So we don't want to oversell the improvements that we've got there. There is a lot to do still there, but it just goes to show the improvements that can be made and the improvements that we've been able to make through our staff experience improvement programme, something that Claire Radley, our Chief People Officer, has been leading through the organisation. And this breaks that down in a bit more detail. There are about 7 or so people promises that are agreed nationally, and you can see the score in 2023 to 2024, and whether it's a statistically significant change there. So we've built on all of those, but as I say, there is still a lot more to do in the staff survey. But what's really important is we still encourage people as much as possible to complete the survey, tell us what we need to do. One of the things that we focused on over the course of the past year that was a big driver of poor staff experience was the issue of boarding. So these are patients that we move out of the emergency department. There isn't a bed available yet, and we put them on a trolley and we will put them on a ward under fluorescent lights and sometimes, often without the right sort of support around them. And the idea behind that was that it would then encourage discharges on the wards, and then we would get that patient into a bed, etc. That was the theory. It doesn't always work like that in NHS organisations, and Gloucestershire's no different from anywhere else. But we really paid attention to that. And last year, around the 14th of July, we made a commitment, and people like Matt, our Chief Nurse, Mark, our Medical Director, and Al, our Chief Operating Officer, made a commitment that we would not be boarding on wards unless we were in a major incident territory. And so we virtually eliminated boarding over the course of the year, and that will have had an impact as well on the staff survey. So again, that's one of those things where that's what staff are saying concerns them about the quality of care. This is what we're doing in response. And so that just gives you a bit of a sense of where we are from a staff survey perspective. And then I just want to talk about a few of the service developments that we've been focusing on. Lots of work I've mentioned earlier about the HASU at Cheltenham. That's made a real difference as well. I think when I was about to join the Trust, I came to an annual members meeting and I heard Kate Hellier, who's the clinical lead and our Deputy Medical Director, talk about the numbers of patients we can count now whose lives have been saved as a result of this. So again, we can quantify that from a mortality perspective. We've done similar around the urology clinic, centralising that. There's lots of benefits of teams working more closely together, so you get lots of benefits there. During the course of the year, often our CQC conversations can be quite negative. It's one of those things that whenever you read those Ofsted stories in the press, that sense of foreboding when inspectors turn up. We had a good rating for Cheltenham during the course of the year, but of course that was offset alongside another requires improvement and a warning notice for maternity. So I'll talk about that in a second. And then one of the things that we've done over the past few years, so before my time, so it was just completed during the course of the year, was a significant investment in the tower facade, so £11 million. One of the challenges with that, from a personal perspective, is that's a lot of investment on the outside of the tower. What we want to make sure is that we've invested significantly on the inside in terms of the working environment for staff and the caring environment for patients, because that is a tower block that's been there since 1975. I think it had a life expectancy of about 30 years, so we're well beyond that. And that causes some real challenge for those of you that have been in and out of the tower block, some real challenge there. And as Deborah alluded to earlier, lots of work that we need to do around fire safety, asbestos, but that is just one part of our estate that we need to focus on. And then digital and operational advancements. During the course of the year, we recruited Lee Pester, our new Chief Digital Officer, came to us from Plymouth. I think Lee's in about month 6 at the moment and starting to see the breadth of digital improvements that we need to make. But again, given the National 10-Year Plan is about that shift from analogue to digital, there's huge opportunity there. We also think there's a huge opportunity to secure funding as well. We think this will be one of the areas that will be invested in centrally. So we want to make sure that we are seen as an organisation that is a good investment when it comes to these sorts of things and we deliver benefits for staff and patients. I'll cover off some of the challenges during the course of the year. As we look forward rather than as we look back. So continued demand across urgent and emergency care. We need a different solution for how we support minors patients across Gloucestershire, because it isn't serving patients well at the moment, and that's something that we're focused on addressing during the course of this year. We've mentioned about the non-criteria to reside, the patients that could be supported elsewhere. That's plateaued. What else is there that we need to do? How are we looking at other regions for continued improvement? And I just want to expand a little bit on the investment in the quality and safety of our estate. Deborah talked about the focus on health and safety, and I think one of the reflections that I've had since joining the Trust is often we see health and safety separate from patient safety. And what we want to do is make sure in our organisation they are the same thing. There's also a staff benefit there, obviously keeping our staff safe, in all of that. We've got parts of our estate here in Cheltenham that have been in use since 1848. Now, it's very, very difficult to deliver modern healthcare in that sort of environment. When I talked about the elective performance, so the reduction in waiting lists that we've delivered as a trust, that's in the context of how often we end up having theatres break down, we end up having floods in endoscopy, we end up having sort of IT failures that impact on our services. So I always think actually it gives me a sense of hope that if we can address some of these sorts of things, imagine what we could do in terms of that next leap in an improvement for patients and access. Overall, we think at the moment there's about an £85 million backlog bill for estates, but we think that's slightly undercooked, and we're doing some work at the moment called a 6-facet survey through our colleagues at GMS to really quantify that and focus our minds as to where we go next on that. Some of it will mean that we want to dispose of buildings, because there is no point in pouring good money after bad in some of our buildings, so we can dispose of those. We can get much better use in terms of space, etc. So that will be a big focus. I've talked about digital infrastructure. Karen's talked about financial constraints and the need to live within our means. That isn't unique to Gloucestershire. That is a national expectation, and I think probably a tougher expectation under the new government. What's quite interesting, when you hear Karen talk about our financial position, and then if you went to another annual members meeting just down the road, you would hear a much bleaker story around all of that. So it can feel like we are in a really difficult position, but sometimes that comparison is quite interesting, just how challenging it is elsewhere. And then, of course, Deborah alluded to the NHS 10-year plan and what the ask is on the NHS to do something fundamentally different to cope with that change in demographic, etc. And one of the things that we really want to articulate ourselves and really sort of tease out with our partners is what's our role in providing and supporting a neighbourhood NHS, because that is a big ask. The NHS or the various governments over many years have talked a lot about shifting care into the community, and this one has to be different in terms of this ask, because otherwise we are only going to be doomed to sort of repeat the cycle that we've seen over the past 10, 15 years. I want to talk quite a bit about maternity here, and then I will wrap up. Maternity has been a significant focus for all of us over the past year or two. When I joined the Trust, about 2 weeks after I started, we had the Panorama programme, and of course Deborah alluded to the reports that we commissioned. So it's not only in the context of significant media scrutiny, but it was also in the context of significant regulatory scrutiny. Maternity nationally is under a significant challenge. There are about 730 odd national recommendations when it comes to maternity services. So actually there's almost a sort of too many recommendations for us, for NHS organisations to really focus on. And one of the things that we've been, during the course of the year, was that we were issued with a warning notice, a Section 31 notice by the CQC, which mandates a number of key actions that need to be taken. Some of those things relate to governance, how we work as a team, how we make sure things are reported and flagged. Some of them relate to our interventions when a woman is in labour and is at risk of hemorrhaging. Some of it relates to our staffing levels. And so we've done a lot over the course of the past year or two in all of this. The reports that Deborah alluded to were two reports, one looking at maternal mortality from 2017 to 2023, and the other one on neonatal mortality from 2020 to 2023. And this was we did this not so it would confirm that we were doing all of the right things, but we genuinely wanted to know, are there things that we are missing when you zoom out from individual cases and look at these things in the round? And there was there's been some useful learning in all of that, but there's also been areas that we got wrong at the time, which caused harm to mums and to babies. And so for that real recognition that we are accountable, we're responsible for that, and a deep sense of humility about the impact that that these issues have had on some local families. Over the course of the summer, before we published the reports, our clinical teams were working and meeting with affected families face to face to make sure they understood what it was that we were doing and what we'd found. And so for us, one of the things that was really important is that in 4 cases at the time, we didn't flag the 4 baby deaths at the time for investigation. That meant we also didn't honour our legal duty to be open, our duty of candour. So we didn't sit down with them and tell them what went wrong, and we're now putting that right. Obviously, that is late for us, and it was wrong. But the other thing is that we recognise that in some of those conversations, by doing this work, that hasn't been without consequence. That's caused some distress to families, and that's something, again, we own. And for some families, actually, they've lived with unanswered questions for a long time, and what we hope through this work that we've been able to offer some more clarity around that. And I think most of all, from a personal perspective and a board perspective, a deep sense of we are deeply sorry for the impact that this has had on mums, babies, and families, because we have to acknowledge, we have to own up to those sorts of issues when we've got things wrong. I think it's something that other organisations could learn from some of the experience here, the good and the not so good. So there's something there for us, and I'm glad that we were able to do this ourselves and not have it done to us, because I think that was important. Because when we talk about culture change within the organisation, we think sometimes that's just about our behaviour to one another, but it is about our behaviour to patients, how open, how defensive we are or aren't. And I think there's plenty of times when we are defensive and we're not really open to challenge from patients. And so that's something for me was a really important part of the cultural shift. And then this week you'll have heard in the media that we are one of 14 trusts that are subject to a national review. And those trusts have been selected based on geography, based on demographics, based on sort of a range of issues, including some trusts that have had national reviews done before. And the idea is that Wes Streeting wants to pull all of that learning together and have a single set of recommendations. Now, it'll be interesting to see how all of that works through. This is still sort of live news for us, but the expectation is that there'll be an interim report published by December and a full report in the spring. But we're going to have a really important role to play, not only in improving maternity care in Gloucestershire, but also shaping the learning and improvement that will happen and come out of that nationally as well. I want to just go on to a video, I think is next, just to show you some of the things that we've done in maternity. One of the biggest improvements that we've made is an improvement in midwifery staffing in particular. We have more midwives now than we've had ever before. We've made some really good inroads into recruitment, and this just gives you a sense of how of actually the importance of that role. But it's really important that we don't see maternity just as about as midwives. There's a whole team of other people, obstetricians, sonographers, etc., that all work around mum and baby as well, that we've been focusing on. But this will hopefully give you a sense of what we've been doing.
A beating heart, a new life start. From the very beginning, a calling, a bestowment to deliver on life's most extraordinary moment. Prepared for decisions, admissions, precision.
And breathe.
Staying calm, learning, sharing, breathing. Waters are breaking, contractions, dilation.
Doing so well.
9 hours, 6 minutes, elation. And then
Tea toast.
a lifeline, mentor, guided support. For parents, for peers, a trusted cohort. Here, you have choices for different paths and different models of working. And voices for speaking out and being heard. One push at a time for rotation, innovation, transformation, integration.
Welcome to our meeting.
We celebrate our teams, give due recognition, opportunity, possibility. We're nurturing ambition. We are the midwives of Gloucestershire hospitals. Join us. A new life starts today.
So that just gives you just a brief glimpse at what we've been doing from a recruitment perspective, but there is a lot more to do that we need to get right from a midwifery or maternity perspective. It also is that the lessons and experiences in maternity are applicable to other parts of the organisation as well, so we're keen to make sure that that is something that we spread across other parts of the trust. So what does all of that mean? When we add all of that together, what does that mean in terms of how we compare at the moment as an organisation? A week or two ago, the government published its league tables. And so league tables were a feature of the NHS back in the mid-2000s, and I sort of joke a little bit about how Oasis have been reformed, and now we've got league tables and some of those things that were here about 20 years ago coming back in. And the reality is that NHS folk don't like league tables, but at the same time, we're ultra competitive, so we do sort of secretly like them as well. And what the National NHS Oversight Framework, it's a fairly technical, dry sort of title, looks at a whole range of indicators, the sorts of things I've shared today and much else besides, and pulls those together in an aggregate score. And a week or two ago, we were placed in segment 2. So 1 is good, 4 is not so good. And we were just on the cusp of a 1. And that gave us a rank of about 17 out of 134. And when we compare like for like in terms of large acute trusts, that we were about the top 3 in that. When we looked at that, we sort of thought, so we come to work every day and we see the problems and challenges that we've got. And sometimes that doesn't quite feel like what we see there, because we know and we're open enough and challenging about ourselves enough that there is so much that we need to do and we need to improve as an organisation. But it also gave us a bit of confidence as well that some of the things that we're doing, the improvements in ambulance handover times, the focus on things like cancer performance, things like elective performance are making a difference. But you can see there, high performing on access to services, finance and productivity, although that's going to be severely tested over the next 12 months, effectiveness of care above average, but patient safety and people and workforce, that's driven from our staff survey, below average. So you can see those areas where we are pushing on, those areas where there's still much more to do. Those rankings will come out once a quarter. I think you'll see big variation quarter by quarter as they get embedded. So we don't want to oversell those. We don't want to over sort of congratulate ourselves, because there is so much more to do. But what I would be open enough to the challenge that we are really up for this as an executive team and as a trust board, that we want to make sure that we get those areas that we are grappling with and struggling with to be in the high performing category as well, because the folk of Gloucestershire demand and expect nothing less. So a huge thank you to the executive team, because they do a huge amount of work, and colleagues like Alex, Neil, others in the organisation that are really driving these improvements, working with clinical teams that can't join us today. Chair, thank you.
Thank you, Kevin. And again, if you have questions in your mind that have been stimulated by Kevin's presentation, then please put your hand up when we get to the question and answer session. I'm now going to invite our lead governor, Andrea Holder, to talk to us about the Council of Governors, who's on it and what they do.
Thank you, Deborah, and good afternoon, everybody. So this year we thought we'd do something a little bit different. So in a moment you're going to see a couple of videos, one from me and one from my colleague Emma Morby, that actually will promote and tell you what we've been doing over the last year. But this was our governing body up until March, April time this year. We are currently in the middle of a governor election process. This is something that happens every year, where we see on average a third of our governing body change, basically. So this year we've tried different ways to try and encourage people to put themselves forward or be nominated to become a governor of the trust. So we've made the videos, which promotes our work, which you'll see in a minute. We've tried, where possible, to attend a lot of the community events that go on. And we've also, for the first time, I think, this year, had a stall in the atrium at Gloucester Royal to try to encourage people as they're coming in and out of the hospital to learn more, not just about becoming a governor, but what it means to be a member of the trust as well. So before we go on to the videos then, I would just like to thank those governors who are coming to the end of their term or who are choosing to move on to pastures new. Your commitment, experience and attendance at all sorts of events is really appreciated. We couldn't do the work without you. You will be missed, but hopefully you will stay as members of the trust and we can keep the contact going there, particularly with community events. Thank you very much. As I say, we hope that whatever you choose to go on to in the future will be beneficial and of value, not just to yourselves, but also in the wider context of the community. Thank you for listening, and I believe we've now got 2 videos. Hello everyone, my name is Andrea Holder. I've been a governor here at the Trust for the last 4 years, and for the last 2 of those 4 years I've been the lead governor. I have a background in the NHS, both clinical and managerial, having qualified as a paediatric physiotherapist long time ago, and moving into different roles throughout my career. I also had the opportunity of working at national level for the Care Quality Commission and the Department of Health. I became a member of the Trust, coming to the annual members' meetings and receiving quarterly newsletters. And I said at the first meeting that I came to that I would be interested in becoming a governor. I applied and was successfully elected. It's very interesting as a member of the Trust because you do receive regular updates and information about what's going on in the Trust. And so you hear it from the actual perspective of the organisation rather than just the noise outside. The life of a governor can be as busy or not as you wish to make it. We have, for all of our governors, we have a minimum requirement for attendance in any 1 year, and that's usually 4 Council of Governors meetings. But over and above that, how much you choose to get involved really does depend on your interest and the amount of time that you have, because we are all volunteers at the end of the day with other commitments and life outside of the Trust. One of the other really important and interesting events that we do is that we do governor walkabouts in conjunction with our non-exec colleagues, and we visit all areas of the Trust. It never fails to amaze me when we do these visits how much time the staff put into actually preparing for us coming round. Given the pressure that everybody is on in terms of their daily function, we are nearly always presented with a really detailed presentation of what they do on their day-to-day job. And equally, we always get feedback of how grateful they are that somebody's actually taken an interest in visiting them. The most challenging part of the role for us as governors is, without doubt, engaging with the public. It is incredibly difficult to actually go out into the communities and try to encourage people to become members of the Trust. Over the last year, it's been very busy. The Trust has been very busy, lots of pressures internally and externally. And so I think one of the things that was a real highlight to me last year, after all the pressure that everybody is under, is the annual staff awards ceremony. As lead governor and in conjunction with my staff governor colleagues, we are asked to review the nominations that come in for staff awards. There are numerous different categories. I think last year there were 13 different categories, and there were over 800 nominations last year. The evening itself is absolutely phenomenal. Some of the nominations were just amazing, and staff really do deserve the recognition for when they go, not just doing their day job to the best of their ability, but going over and above that extra mile for the patients in their care. It was a tremendous highlight for me last year. We are very much appreciated as a Council of Governors within this Trust, and so it's important that we hear and represent the views of our local constituents.
Hi, I'm Emma Morby, and I'm one of the 2 public volunteer governors for Gloucester. My background is about 15 years in industry, and then I moved into consultancy and worked all over the world. I've been a volunteer public governor now for just over a year. So what drew me to the role? I think a big desire to see patients getting diagnosed earlier. Early diagnosis of medical conditions is really important to me. And I want to see our Hospitals Trust become a place that recruits, develops and retains the very best talent that we can. in every job, in every area, always. And the midterm focus I have is about really starting to make sure that we get more of our services into Gloucestershire. And I think medium term as well, there's something for me about some very specific medical conditions that we really need to be working on earlier diagnosis and treatment for, again in county. And so that would be things like endometriosis, adenomyosis, gender dysphoria, assisted conception for women in same-sex couples, and for things like disordered eating and for young people's mental health. Those things we need to have early diagnosis, proper support, and we need to have those services in Gloucestershire where we can access them in a timely fashion. So what have some of the highlights been of my first year? I think the most important has been listening to patients, whether that's here in the Hospitals Trust or one-on-one out in the community or on the NHS community outreach bus and events. And that bit about patients sharing their stories, sharing their experiences, so we can bring that back into the Hospitals Trust and work with it to make care better is really, really important to me. And then the other bit is listening to staff and seeing where they work and how they work and what they do. Because the more you see of them, you realise what extraordinary people we have in the Hospitals Trust. But you also realise that the NHS is our people. And that's why recruiting the right people, developing in them and training them and supporting them and making this a place they love to come to work and want to come and work in is so vital for our future. So, how can we help the Hospitals Trust? Talk. It's a really important thing. It sounds really simple, but it's vital. So talk to us at the Hospitals Trust, either one-on-one or while you're in the Trust itself or at the NHS community outreach events. Share your experiences, share your learning, share your ideas, share it so that we know your story and we know what we're good at and what we need to change. And similarly, talk to our patient advisory and liaison service team. They're the most incredible group of people in our trust, and their job is absolutely to listen to you. And then finally, you, I, our families, our parents, our grandparents, our great-grandparents, we chose, we created the NHS back in 1948 because we wanted all of us, everyone, all the time to have better healthcare. And I look back on that generation in 1948 that chose to create this amazing, amazing space, these people, these teams, this healthcare. And I look at them and I think they did something amazing for us and for our country. And then I look at all the spaces I'm in and all the people I listen to and work with, and I go, and now it's our turn. So it's our turn to do our bit. So please do join us as a public member of the Trust. It's free. And your opinions, your views, your experiences is what will shape our healthcare going forward. So your voice is vital to the NHS. So please support us, please get involved, and you will be the person who makes the difference in Gloucestershire for you, for me, for your family, for mine, for all of us. Thank you.
Can I thank everybody for your attendance at the meeting? I think we've had some very interesting dialogue there, and I hope that's been a useful insight into the Trust and how we're delivering services and how we work. Thank you very much.